Okay, so maybe we'll get started here. Thank you all for joining. I appreciate it. Hopefully, you guys are at the right place. But today we're going to be talking about a procedure, minimally invasive procedure to treat osteoarthritis knee-related pain. So see this slide here. This is our company, IR Centers, which we specialize in different types of minimally invasive care, but our expertise is in these high-end type of embolization procedures. So a little bit about me. So I'm an interventional radiologist, as is Dr. Khan. I'll introduce him in a little bit. But I did most of my training in Massachusetts, moved down here about almost 3 years ago to join this practice where specialize in kind of some of these high-end embolizations. Dr. Khan, who's new to the community, but he's been in IR, got his degree from Stony Brook University and completed an IR-DR or interventional radiology and diagnostic radiology integrated program at Albany Med. And he was a chief resident, which is a pretty high distinction that you get elected in your training. And now he's one of the experts in minimally invasive therapies, including GAE, which we're going to talk about today. So to take a step back, so in a nutshell, what is vascular interventional radiology, or why would you see an interventional radiologist for knee pain or really anything? So interventional radiology, it's a subspecialty where you essentially use imaging to either diagnose or treat disease. It's kind of on the cutting edge of different technologies because the push is to make everything smaller and smaller and smaller with less downtime and less risk and less recovery. So these procedures that we do, we're doing them basically through the size of essentially like a tiny hole, a couple millimeters big, almost like a pinhole. So GAE is no different from that, and we'll kind of go into detail about that. So what are we here today to talk about? It's called knee osteoarthritis. Obviously, it's very common in the United States. 30 million people in the United States are affected by osteoarthritis, with the knee joint being the most common site. There's over 100,000 hospitalizations a year annually, just related to toxicity related to NSAIDs. That would be like your ibuprofens, Aleve, Motrins, what have you. Almost over 16,000 deaths even related to NSAIDs in the setting of osteoarthritis pain because people are in so much pain. There's more than 4 million knee injections annually, including steroids and Synovisc. I don't know if anybody who's on the webinar today have had knee injections, but they actually work really well. We do them in our office, but it's usually something that kind of tapers or doesn't work as well over time. It's not something you just keep doing forever where it will work. So you'll see GAE kind of fits this sweet spot. So what do we have for treatment options? So we talked about joint injections. That's going to be that cartoon third from the left. And then obviously the very last thing that you can go for is what's called the total knee arthroplasty or knee replacement. Those are those two images, one all the way to the right and the second one from the left. Obviously, it doesn't look super appetizing there, but it does work in vast majority of patients. There are a small percentage of patients, it can be, depending on where you look in the literature, 10 to 25% that may still have knee pain even after total knee arthroplasty. So that's something to keep in mind. It's not infrequent that we treat those patients. And then the other one image that they have on the far left is called genicular artery ablation. So that's where they basically try and dull the nerve endings, so it reduces the sensation of pain. So rationalization for embolization, and that's what we're talking about today. Now, this is kind of getting into the weeds a little bit, but what I end up telling patients is that so with knee pain, there's some underlying cause, whether it was a trauma or just regular wear and tear. But what ends up happening is the synovium is what lines the joint. And its job is basically to deliver nutrients to the joint. It also lubricates the joint, so it creates the same amount of fluid as it absorbs in a day, or it's supposed to, right? And if it gets out of whack, then you can have too much fluid in your knee that's produced by the synovium, whether it's making too much fluid or not absorbing enough. When you have that injury, the synovium is where the blood vessels nutrients basically come from. It ends up releasing these cytokines and VEGF factor, which you don't need to know what that is, but essentially it causes angiogenesis or neoangiogenesis. What that means, that's just a $4 word of saying new blood vessels are being created. And it makes sense, right? So there's an issue. Your body's trying to help or fix that issue. So it tries to recruit more blood flow so it can recruit more nutrients. The problem is that cycle actually perpetuates a pain cycle. And that's kind of where GAE or genicular artery embolization comes in. It basically stops that cycle that's caused by those new blood vessels. Now, this is a cartoon or depiction of that. There's people a lot smarter than I am who dedicate their life to understanding this, and that's kind of where we get this from. So genicular artery embolization is a treatment for pain secondary to osteoarthritis. So that's what we're talking about today. This is our group. We published this, which basically showed improvement in patients who underwent GAE with improvement in pain on the visual analog scale, and also WOMAC scale, which are these different markers that we use to try to qualitatively look at knee pain. Just aside, not this past year, but the year before in 2023, we got outstanding abstract of the year from our society for our work on GAE. So we really are kind of leading the field or leading the charge when it comes to this. This is just to kind of get into the details about this, but 100% of patients at 1 month had significant decreases in WOMAC, which takes into account function and pain, and then 95% significant decrease in VAS, that's visual analog scale, which is self-reported pain. 6 months at 6 months, 80% had significant decrease in WOMAC and 85% in VAS. So, comparing that to knee injection or joint injection, which we are leading a study for that right now as well, but that's going to be significantly higher at that time. 65% decrease in NSAID use at 6 months. And as we talked about in the beginning, NSAIDs aren't without their own risks, right? Those hospitalizations and even those deaths related to NSAIDs are not an insignificant amount. So this is just to kind of go over further that we've compared this to sham, which is kind of the standard. There's not many randomized sham studies in our specialty. This is one of the few. Going through it even further, those patients who crossed over or they went into the sham side, which that just means there's a patient that they don't know if they're going to get the treatment or not. They undergo like they're going to go into the treatment. We even inject contrast in there to almost mimic like they were going to get the treatment. And they didn't see any significant improvement until they were allowed to cross over at 6 months and they got the GAE, and then they all showed improvement as you would expect. There's just more of that literature. There's been meta-analysis just proving this over the last 10 years. So who's a candidate for this procedure, GAE or genicular artery embolization? It's going to be patients who failed physical therapy, patients who've had joint injection in the past or an ablation in the past, that it isn't working as much as it was before. Patients with blood in their knee or hemarthrosis, mild to moderate osteoarthritis. So severe osteoarthritis where it's bone on bone, it may not help as much. So those patients we may advise that maybe you should go for your total knee. But patients who can't undergo surgery, we still may treat. And then one good predictor, and oftentimes if we do a consult with you over the phone, we may bring you in the office just to kind of see if everything lines up, is palpable pain, meaning if we press on the area where you have knee pain the most and we can elicit that or reproduce that pain, that's a good positive predictor that you're going to do well from this procedure. So what's the workup like? We'll typically get imaging, or your orthopedic surgeon may have already gotten imaging where it may be an MRI. We may bring you in for an ultrasound, just routine labs, and physical exam, as I mentioned, to assess the site of maximal pain. And most patients will have them get orthopedic evaluation. So this is going to be a cartoon depicting what the procedure is. So before I kind of press play here, to take a step back. So this is done in our office as a day procedure. So you come here, go home the same day. All in all, you're with us for about 3.5, 4 hours. So you get here about an hour before. The procedure itself takes somewhere around 30 to 60 minutes. So say even on the longer end, we'll say about an hour. And then recovery is about 2 hours. So all you're with this for 4 hours. You cannot drive yourself that day because we're going to give you moderate sedation so you're comfortable. So you would need a ride. But the procedure itself is really painless. There's not much recovery or downtime. Only thing that we ask is if we go through the blood vessel at the top of the leg, no heavy lifting or strenuous activity for 5 days. We go through the blood vessel at the top of the foot. You'll leave with us a little bit sooner, and the restrictions might be a little less, but you still want to take it easy for a couple of days. So with that being said, I'll kind of give the cartoon, and this will kind of give us a better idea. So in this particular cartoon, we're going to go through the blood vessel at the top of the leg. We'll use a small catheter, which is a long, thin, hollow tube, about the size of a long, thin piece of spaghetti, more like an angel hair pasta. We're talking food here. We'll go to the blood vessels that supply the synovium or the knee joint, take pictures, find those inflamed ones with the neovascularity, slow down the blood flow with these micro particles that will slow down the abnormal blood flow, but allow for normal flow in the parent vessel, and then take the catheter out. So it's as simple as that. There's typically, so if you have knee pain on the inside of your knee or the outside of your knee, there may be different blood vessels that we would address. I have some slides in here that kind of gives you an idea of what we're seeing when we're doing the procedure and how obvious it actually is. But depending on the numbers, then here, let's see here. There we go. Sorry about that. So yeah, so there's different anatomy and different blood vessels that can go to those areas. So it's kind of this is I know the cartoon was pretty clean looking, but here this is what a knee looks like with bad osteoarthritis and inflammation and neoangiogenesis of the joint here. So this is just depicting one of the culprits, which is the descending genicular artery here. I don't know if you can see my laser pointer here, but so this is one of the branches that we would target. Kind of going through here, I want to kind of impress upon you what it looks like before and after. I have some slides here in the end. So here, this is the image on the left is what we see when we have a patient who has really bad knee osteoarthritis and synovial inflammation and synovitis related pain. So as you can see, it's not too difficult to see, but there's this blush or like this smudgy gray area, which that's that neovascularity. So this isn't normal blood flow, normal image on how the knee joint should look. So what we end up doing is we administer those particles that are sized for these smaller blood vessels, but they won't stay in the larger blood vessel. So what ends up happening when you're done treating it, you get a picture like this on the right-hand side where it's a nice smooth blood vessel where you're still seeing blood flow going to the joint, going to the synovium, but that abnormal inflammation is now gone. And in turn, that reduces the pain. So I have an example of a case. So this is a 57-year-old gentleman who had already had treatment for his knee OA. He had a right knee hemiarthroplasty about 10 months prior to when we saw him, and he still had persistent pain. And like I mentioned, up to 25%, depending on where you look, can have persistent pain after a knee replacement. Patient still had recurrent effusions and multiple aspirations, meaning we drained the fluid from his knee prior to the procedure. He had pain most at the superior lateral aspect, so that's the above the joint line and to the outside of the knee. And on examination, he had tenderness in that superior lateral area and as well as the medial area. So that examination is critical for us determining kind of where we're going to target. So here you can see he had a partial knee replacement or a hemiarthroplasty. So that's what that device is that you see the blood vessels going all the way there, and then all of a sudden it stops and you see the blood vessel again. That's what that is right there. That's blocking our view. But here we get into this blood vessel, which usually contributes to medial knee pain or inside the leg knee pain right here. And then when we do, you see that blush. That's very obvious. So what we do is we end up treating it with those microparticles made of the medical grade plastic, which is on the order of 100 or a couple hundred microns big. And then we slow down the blood flow in these abnormal ones, but maintain blood flow in the main blood vessel. We also treated that lateral side or the outside of the knee where you get that similar effect. You see this kind of inflammation here, this abnormal inflammation. And then after we treat, it's essentially gone. So post-operative course. So what to expect? So discharge home the same day as I mentioned. We do prescribe an NSAID for time afterwards. It's about a week or two afterwards. Patients may experience a lace-like skid redness or rash. You can see on this patient, they have a slight rash. It does go away in a few weeks. There may be some stiffness. Stiffness may be worse for the first day or two, which afterwards, actually, the range of motion will actually improve. We reassess at 1 month, or we'll assess you at 1 month just to follow up to make sure you're improving the way that we expect. But we do expect to have improvement in pain probably within 2 weeks, and it'll continue to improve up to a month, and then even after that. I'd say probably at the 3-month mark, you'll reach kind of your new steady state, and that's kind of what you would get out of this procedure. Oftentimes at that time, most patients who have second knee at the 1 month and they have another painful knee or joint, they'll ask us, hey, can you do the other side? But usually we wait that month before we'll bring you back in. And that is all I got. Hold on 1 second. I have contact info here. 1 second. I'm just going to stop sharing my screen for 1 second because I have another slide that I want you guys to have, and you guys will get this all as well. Can get this all by email. In the meantime, Dr. Khan, do you want to go through, were there any questions in the chat at all? Does anyone have any questions or
Doesn't look like we've got any open questions in the Q&A section, but if anyone from the audience has any questions, we can certainly help to answer anything at this time.
Here we go. I'm just going to share this slide too. This is any contact info if people want to schedule consult. This is Dr. Khan's contact info. Or it looks like we got some questions coming in here. So one question, is the procedure covered by most insurance? Yes, it typically is. It is covered by Medicare. Are blood clots something to be concerned about? No. So unlike with total knee replacement, there's not that downtime that you would typically have. Really, the downtime is no heavy lifting or strenuous activity. And blood clots are usually seen when you're bedridden or laying in bed for an extended period of time. What keeps the particles from moving elsewhere? So what we're treating are something called arteries or blood. They supply the oxygen-rich blood to the tissues. So they're under a high pressure system, and the blood is pumped forward by the heart. So it's kind of flowing in one direction. Now, it is possible that it could potentially go somewhere where you don't intend. In this procedure, it's not very common. And actually, a lot of times the embolic that we use is temporary, meaning it eventually reabsorbs. Places where it could go is potentially the skin. Really, most of the time, all you'll see is that rash. If I've had injections and they more or less work, am I a candidate for this? Yes, you are. Actually, having a response to joint injections is also a positive predictor of you doing well with this procedure. Cost, I honestly, I don't know the cost. That's something our team could get to you if you have the consult. But like the earlier question asked, it's typically covered by insurance. How long does it last, and how soon can you have it done again? Do you need a referral? So you may need a referral depending on your insurance, but if you reach out to us, we can sort that out. If you need a referral, we set you up for a consult. How long does it last? There's no reason why this couldn't last for an extended period of time, like over 12 months or 2 to 3 years. It can be repeated, but the only time we would repeat it is if you got significant improvement in the past. We've had repeated on patients who years down the line, they said, hey, this worked really well for me. I'm still really active. I don't want to go for surgery yet. Can you try it again? And we do it and they do well. So it can be repeated. It's not something that we would typically repeat though within a year. What are the most common complications? Approximately how often? What happens to these plastic particles are limited by the liver? So most common complications, first off, this is a minimally invasive procedure. Complications are not common at all. I would say the ones that we kind of go over with patients the most, anytime you're taking something from outside the body to inside the body, there's always risk of infection. We use sterile technique and we give you antibiotics, so that risk is small, but it's never going to be zero. Risk of injury to a blood vessel or bleeding. But like I said, we're using image guidance throughout the procedure and to get into the blood vessel. So if we went to the top of the foot, we'd use ultrasound to get in, and we'll hold pressure and monitor you for the time after the procedure. And if we go in through the larger blood vessel that's at the top of the leg, we'll use a closure device. So that risk is small. And then the other thing that I always mention to patients is, as far as complications go, is non-target embolization, that's what we're talking about. If it goes to, like in this case, maybe the skin, it's going to be very small, exceedingly rare, less than 1% chance. Hi. So someone's asking specifically about if they would be a candidate. I would encourage people for specific circumstance to try and schedule a consult with Dr. Khan, and he can go over all those details. But yeah, wear and tear and osteoarthritis is a good indication for this procedure. Do you have any results compared to PRP? No. So right now, I'm one of the principal investigators. We're conducting the largest study. It's a global study comparing directly joint injections to GAE. So like I said, we had it to sham compared to nothing. But not directly to PRP. But the idea would be that this would be a single procedure that you would get longer durability, and that's what's weighed out so far in the literature. If I have high blood pressure, is that a problem? Typically, no. A lot of our patients that we treat are going to have high blood pressure on their problem list. Now, if the blood pressure gets really high, like in the 200s systolic, then it can be issues with post-procedure bleeding. But it's not a contraindication by any means. A lot of our patients will have high blood pressure. Sorry, Dr. Khan, I kind of just rolled through all that. Do you have anything you would add to any of these here?
No, that was great, Dr. Pavidapha. Thanks. There's another question. Is there an issue if I've had a partial meniscectomy? No, a lot of the times we'll see patients who are post-operative, and patients do really well after the procedure as well. So that doesn't prohibit you. And I think you'd be a good candidate if you do have pain after having surgery.
Okay, well, thank you. There was quite a few participants and a lot of great questions. I hope this was valuable information. Oh, did we get another? Yeah, we got one more. Any long-lasting side effects? No, typically no long-lasting side effects. If you had an infection, it's usually been treated. If there's an issue with bleeding or the injury to the blood vessel, that also would not necessarily be long-lasting. But yeah, so if you'd like to schedule a consult, learn more about this and see specifically in your circumstance, if you'd be a candidate, please reach out to Dr. Khan or Dr. Khan's office. I'm happy to help in any way. We can share my information as well. But we're really excited to have Dr. Khan with us to offer this high level care in the community. And I think a lot of people can benefit. We've seen a great impact for the patients that we've already treated, and we know there's a lot more out there. So, I'd like to thank you guys for your time, and please reach out. Anything you'd like to add, Dr. Khan?
I think that's great. Yeah, if you guys have any questions or would like to see me in consultation, we can just go over everything one-on-one and your own personal, go over your medical history and make sure you're a good candidate. And feel free to reach out through the contact info listed. And I'm looking forward to meeting you guys.
Right. Okay. Thank you.